Good afternoon, everyone. We talk about my PhD project entitled Technology Assisted Healthcare, Exploring the Use of Mobile 3D Visualization Technology to Augment Home-Based Fall Prevention Assessments. So the outline of the presentation is I'm going to start off with a background, then I'm going to talk about the literature survey that I conducted and the conceptual framework I developed, and then my three iterations in my research, and then the conclusion. So, falls. Falls are a serious health issue, not just, I said, within the UK, but around the world. It costs the NHS £2.3 billion a year to prevent and detect falls. 30% of older adults over 65 and 50% of older adults over 80 fall each year. Fall risk factors tend to be categorized in two different classes, if you will. So the first one is intrinsic risks, which are a natural age and changes that tend to be issues with functional ability, with vision and with cognitive impairment and balance. Intrinsic risks tends to be external factors from the older adult's physical health, so environmental hazards, rejecting the use of or using assisted devices incorrectly. So these are a list of some fall prevention interventions. Interventions tend to be single or multifactorial, so multifactorial in the sense of preventing a number of fall different risk factors. Home-based exercise programs, so a physiotherapist or an occupational therapist might prescribe some exercise programs to an older adult to try at home. Then you've got some psychological interventions that include change in behaviour on how they carry out activities of daily living and how to do it safely. Then you've got home assessments and assisted devices such as bath board, toilet frame, stair lift, and so on. And then you get education, which educates them about the assisted device itself, the use of the equipment, and then you've got technology-enabled interventions, so things like the use of gaming as a way of increasing adherence rates when people are using the game exercises. Exercise programs and home-based assessments tend to be the most effective interventions that's found in the literature. So what I did was I started off with literature survey. So I carried out a systematic mapping study which mapped the area, the different types of systems that are out there. There was a gap in the literature. I found that a lot of the authors were focusing on subdomain areas in falls prevention, so looking at how risk factors are assessed, how they're detected, and how they're prevented. So what I did is I conceptualized the literature, but based on my observations, I developed a conceptual framework. And then I identified some of the challenges and proposed some recommendations. So this is a conceptual model of my what derived from my literature survey. And what I did, these are system types. So the first one is pre-fall prevention, which includes interventions types such as preventing physical activities, cognitive training and education. The other one is got to do with assessing cognitive impairments, functional ability and environmental assessments. The other one tends to be fall detection, and the one here is a combination of the three. I divided the model into tables, and I categorized all the studies that I used to develop the framework into system types. And then I proposed a number of challenges and recommendations, so I took a subset of those challenges, which then forms my research. So I found that there was a lack of focus of reducing intrinsic risk factors, and some of the systems weren't incorporating home assessments and intervention to reduce fall risks. So I developed some recommendations to overcome those challenges. So the aim of the research is to design, develop and evaluate an effectiveness of mobile 3D visualization to support clinicians and older adults within home-based fall prevention assessments. So what I did was I searched through the healthcare literature, and particularly the grey literature, and I looked at how the different NHS trusts around the country carry out their home assessments, particularly occupational therapists. And then I sort of sampled a 2D assessment forms that are used by older adults and clinicians, and I found 9 that I used, which tends to be in-house. Every trust around the country tend to develop their own, almost a checklist in a way, of how an OT would go out to the patient's home and assess the home and to prescribe some equipment. So an older adult might just been discharged from home, discharged from hospital, sorry, and they might need a bath pool to help them with bathing. They might need a stair lift. Depends on the needs of the patient. So I came across, so I used one of the forms that are used in one of the NHS trust. Some of the issues that home assessment interventions face is 50% of the devices are abandoned by patients. One of the causal factors of this rejection is a poor fit of equipment, based on inaccurate measurements that are taken from the clinician, not involving the patient in the selection of the devices, and no decisions that are made in empowering the patient to make decisions on what their needs are. Measurements, it needs to be pointed out, measurements tend to be a well-known source of error in healthcare. You see that a lot with medical devices. If you get the dose right, it can be very, very catastrophic. So the form that's used tends to include textual descriptions and 2D diagrams. Sometimes can influence how clinicians and OTs interpret the guidance to then perform the assessments. So what I did was the first stage, I did a participatory design workshops with older adults, clinicians and interactive designers. I involved the clinicians because some of them were quite skeptical about the use of technology because they felt it could replace them as clinicians. And then I performed some evaluation studies, developed a proof of concept prototype based on the sketches and some user requirements I got from that stage. And in the evaluation part, I involved 33 older patients and 10 clinicians. The first iteration, we came up with some findings. So the first one is that we found that the 3D visualization approach helped with accurately interpreting the guidance. It helped older adults with depth perception to indicate some key areas of where measurements need to be taken within the home. Some requirements were emerged from some open-ended responses we got back from the interviews and focus groups. OTs argued that the 3D app, that the prototype that was developed implies it could be used once. So we had to explore how it could support them as clinicians when they carry out the assessments if older patients are unable to do it themselves. So one of the key points was OTs felt it was more interested in managing their assessments rather than the effectiveness of collecting the data. They're a bit skeptical because it tends to reflect how they assess their patients competently. Older adults experience some difficulties manipulating some of the 3D models, so we rectified that in the next phase. And one of the things that came up out of this iteration was rejecting data entry that is over a specific measurement threshold. So for instance, the length of a bath can't be 100 inches for instance, otherwise it will affect the recommendations that the app might make. And then also involving family members of older adults if the patients have really, really complex needs. So iteration 2 was a user trial. So we carried out the user trial in an independent living centre. And I compared my app that I developed versus a 2D form. And we involved 33 clinicians and 34 older adults, and we carried out a full usability study. So to measure efficiency, we did a log file analysis. So we recorded the time completions, how long it took them to complete their assessments using the app, and how long it took them to complete the assessments using the 2D form. Then we collected the measurements and the other various assessment data to see how accurate the data was that we got back. And then we did some follow-up interviews. I used TAM that underpinned some of the questions I asked in the interview. And then we used a revised version of SAS. We added an additional 4 items, which made it 14. So this is my app. This is some screenshots. There are some parts in the area which indicates what needs to be measured and what needs to be considered if you're prescribing a bath board, or if you're raising the toilet seat, or if the loo roll needs to be within reach. There is another screenshot, but I wasn't able to fit into the slides, unfortunately, which was a list of questions that kind of helped with the recommendations. So the findings from the user trial, so one of the things was clinicians felt that the application could enhance the dialogue between patients and clinicians, particularly when older adults are discharged from hospital as a result of falling. This resulted in a better understanding of patient needs because they were more involved in a selection of the assisted devices. And it also helped with referrals. So if patients really just came out of a knee replacement operation, and they'll be referred to a physiotherapist. The clinicians highlighted the fact that the app helped to standardise how clinicians carry out their assessments in different NHS trusts around the country. Older adults felt more empowered by using the app because they felt they were more involved. They had a say-so in what was being prescribed to them. Some of the textual descriptions of the 2D tool was misinterpreted by some of the users. And then the last study, or the last iteration, we took what we learned from iteration 1 and 2, and then we developed a recommendation function which mapped some of the questions asked about the older adults' functional ability, and some of the questions regarding their daily living tasks. And based on those questions, I interviewed some clinicians, and we came up effectively a formula of how they would go about providing some recommendations. And then we evaluated that function with 5 clinicians. So prescriptions that are made are only as good as the collected data. So if you don't have an accurate picture of what the patient needs, then it's going to affect the effectiveness of the prescription. The 3D tool is more sufficient than the 2D tool we found, again for interpreting the process of assessments and what was needed, and to do with collecting assessment data. So, conclusion. So one of the things I want to point out is the app wasn't designed to replace clinicians, but it serves as an alternative solution. It helped to involve patients in their own care, especially if they don't have access to clinicians. the specialist knowledge that OTs tend to have when they're performing their assessments helps this type of knowledge to be packaged up into a tool where older adults could use it, especially the fact that clinicians only make up 2% of the health and social care sector and handle 35% of the referrals. It also helps with reducing human error in the clinical reasoning and automate steps to work out the specific device that meets the patient's needs. And there's some future research directions. So one of the things I found was, although I did some in the user trials, I carried out a user trial with patients and with clinicians. I feel that the app needs to be tested in an uncontrolled environment, particularly with the falls care pathway, and monitoring adherence rates for the use of the app, and maybe exploring some specific scenarios of how the daily living tasks could be performed with using assistive devices, and some economic evaluations I feel could be used, particularly whether the app helps to reduce costs, hospital admissions, visits to homes, and number of falls and waiting times. Thank you.